Well, I think I'm live. This is Dr. Nick Tulo. I had quite a lot of problems with my setup here. I'm using Livecast and I'm trying to get Livecast and YouTube to talk to each other. And I've been struggling now for almost an hour. So I'm really sorry if anybody has been waiting and hoping that I'd do my Livecast, but here I am. So those of you who didn't see my Livecast last week, I'm a cardiac electrophysiologist, so I practice in the world of ECGs. I read hundreds of them every week. I take care of patients who have serious arrhythmia problems, and I wanted to bring my insight to my subscribers on the YouTube channel ECG Doc. So today I'm going to be talking about trifascicular block, and it is an ECG diagnosis that some people don't really understand. They've heard about it, maybe they read about it in some basic ECG textbooks. And I have some examples to put up and try to teach you what you should be looking for when you're thinking about diagnosing trifascicular block. What does it mean? Why do we refer to it that way? And give you a better sense of how the cardiac conduction system works. So let's see if I can use my camera here. Hey, there I am. And I hope I'm still streaming live. It says I'm live, so let's just go with it. Anyway, just try to record this. Okay, sorry for the interruption. But if I can bring my... Okay, so I think you can see my screen now. And what I'm going to try to do is explain how we diagnose a right bundle branch block and where does it come from. Because trifascicular block is usually considered to be a combination of either right bundle branch block with a hemiblock, so you have bifascicular block, together with the first degree AV block. And then some people will also consider trifascicular block as being left bundle branch block plus first degree AV block. And unless you understand why people have considered those to be consistent with trifascicular block, it's kind of hard to realize. It's hard to remember not only when to diagnose it and when to sort of write it off, but I wanted you to understand why the whole idea behind it. If you add a first degree AV block, does that mean that you have trifascicular block or not? So let's just take a look at this cardiogram. So we have a normal sinus rhythm. You have P waves and QRSs. And when you look at V1, you see a little tiny Q wave, a small R, but then you have a deep S wave in 1 and AVL. Also, you see it in V5 and V6. So the lateral leads, you have a deep S wave, and in V1, you have an RS and then a tall R prime. That's so-called rabbit ears that people describe when they're talking about a right bundle branch block. So first of all, why does a right bundle branch block look like this? Well, remember that your heart lies in your chest, but it's kind of twisted. So the left ventricle is actually behind the heart. It's in the posterior part of the heart. And the right ventricle is actually on the front of the heart. Now V1, which sits right here over the right sternal border, is right over where the right ventricle is. So if you have a right bundle branch block, what that means is that the right bundle branch that depolarizes the right ventricle is firing in such a way that the right ventricle doesn't get the signal. So the signal has to go down the left ventricle and then very gradually make its way to the right side. So the right ventricle depolarizes late. So since V1 is right over the right ventricle, you get these positive deflections in V1 because you've got this late signal that's heading towards the right side. And the reason you have a wide S wave in the lateral leads, 1, AVL, V5, and V6, is because, again, you have late signals traveling towards the right ventricle away from the left side. So that's why you get these negative wide S waves. The QRS complex, the total duration of the QRS, is long because you're not using the rapidly conducting Purkinje system on the right side of the heart. So the right side is depolarizing through slow cell-to-cell intramyocardial connections, and it's just not fast enough. So that's why the QRS takes longer to inscribe. So that's why a right bundle branch block looks the way it does. So let me see if I can do a little drawing here. Okay, so this is my diagram of the cardiac conduction system. Let me pick a nice color here. Sorry, it's taking so long. So, as you know, the sinus node fires and the signal rapidly goes across the top chambers, giving you a P wave. The signal gets into the AV node and is generally delayed, usually less than 200 milliseconds, because that would be a normal PR interval. And then, if everything's working properly, you get rapid conduction down both sides of the conduction system, the right bundle branch, which goes to the right ventricle, and the left bundle branch, which then splits into the anterior hemifascicle and the posterior hemifascicle. So you normally get a very narrow QRS complex and then an upright T wave. So if you just take a right bundle branch block, for example, what happens is the signal is not able to get down the right bundle branch. It's blocked here. So that it has to go down the left side and then gradually make its way to the right side of the heart in a slow fashion. So at least in the lateral leads, what you get is this deep S wave. And in V1, instead of seeing a little R and a nice deep S wave and a narrow QRS, what you see is an R and sometimes a deep S and then an R prime. And this large R prime is the right ventricle depolarizing late. Okay, get it so far? Right? Basic stuff. Okay, so, but then what happens? Here's an example of a cardiogram. Let me make that bigger. And what you see is in lead 1, you have this a little bitty widening of the S wave. And in V1, you have actually a QR prime, but the R prime really isn't all that impressive, is it? It's not super wide. And in fact, the total duration of the QRS complex isn't more than 120 milliseconds. So most people would look at this and diagnose an incomplete right bundle branch block. Well, what does it mean to have an incomplete right bundle branch block? Does that mean you're a little, is it like being a little pregnant? I mean, it's either blocked or it's not blocked, right? So the point is that when you have, the word block is really misleading because it makes you think that that right bundle branch is actually blocked, and it's not, or it doesn't have to be. It only has to be delayed. That means it has to take a little bit longer for the signal to get to the right ventricle, enough time so that the signal can get down the left side and come around again. Okay, so it really shouldn't be called right bundle branch block necessarily. It should be called right bundle branch delay. So on the right side of the heart, instead of this right ventricle being blocked, it's just delayed a little bit. And so you get the same RSR prime in V1 in an incomplete right bundle branch block, but the R prime isn't really that large. Why? Because the right ventricle is kind of getting the signal, but some of it may be a little bit late. So the whole concept is that, so bundle branch block, it's not really block, it's just delay. So the right side gets delayed compared with the left. That doesn't mean it's completely blocked, okay? Now, the reason we start thinking about trifascicular block is that sometimes what we see is a tracing like this, where you have this large R prime in V1, and you have a wide S wave and one in AVL, so it sure looks like a right bundle branch block. But what's the QRS axis in the limb leads? Remember how you have to look for the axis, and if you're not sure about axis, I have a whole course on 12-lead analysis on ecgacademy.com, so you might want to check that out. But you look for the QRS complex that's most isoelectric. And in this case, 1 is clearly up, L is up, 2, 3, and AVF are down. AVR seems to be the one lead that is equal in size above and below the baseline. So that's the one that's most isoelectric. And so AVR is pointing 30 degrees above the horizontal towards the right arm. And so that would mean the axis is perpendicular to that. So since it's going away from the feet, 2, 3, and AVF, that gives us an axis of minus 60. And that's consistent with the left anterior hemiblock. So anytime you have axis of minus 45 or above, or marked right axis deviation, you can call a hemiblock. And again, if you're not really familiar with why a marked left axis deviation is consistent with an anterior hemiblock, then you should definitely check out my video tutorials on ecgacademy.com. It's like having a private lesson with an electrophysiologist. So I make it very clear as to why that's consistent with an anterior hemiblock. But when you look at the PR interval, it's long. So here's in V2, it looks like at least 240 milliseconds. So you have this first degree AV block. So you have a right bundle branch block, you have a left anterior hemiblock, and you have a first degree AV block. So if you look at the books, the basic textbooks, they look at that and they say, well, then it's trifascicular block, isn't it? But why? Why would a first degree AV block tell you that you might have trifascicular block? Well, let's go back to our drawing of the conduction system. So let's pick a crazy color. So let's just say that you have delay in the right bundle branch. So it's taking a little bit longer to get down the right side. Let's say that you also have delay in the anterior hemifascicle. So that's taking a little bit longer. So then what happens is that the posterior hemifascicle, which is the largest of the three, depolarizes rapidly. And then you get depolarization of part of the heart, and then you have gradual conduction through slower myocardial pathways to the right side and also to the anterolateral part of the left ventricle. But here's the thing. If the left posterior hemifascicle is healthy, then the QRS should still get down rapidly. The QRS should still start on time. You get it? So the PR interval should be normal if the third hemifascicle is healthy. Now, the idea of trifascicular block is, what if that third hemifascicle is also diseased, but not delayed as much as the other two branches? So you got marked delay in the right side, you got marked delay in the anterior hemifascicle, but the posterior hemifascicle is still delayed, it's still sick, but it's faster than the other two. So what you get is an appearance of a bifascicular block, but since it's taking longer to get from the atria down the AV node and to the ventricles, the PR interval you would expect it to be prolonged. Okay, so the prolongation of the PR interval potentially comes from delay in all three hemifascicles. Two more delayed than the others, so you get the right bundle left anterior bifascicular block appearance, but the third hemifascicle is also diseased, and that's why people will diagnose trifascicular block. But here's the thing. How do you know that prolongation of the PR interval? How do you know? that, so how do you know that the delay in the PR interval is from the third hemifascicle? How do you know that the delay isn't just higher up in the AV node, right? So, for example, okay, just make sure I'm there. So what if the fact that you have a long PR interval and then you've got this bundle branch block pattern, so the PR interval is more than 200 milliseconds. How do you know that the delay in that PR interval isn't just coming from AV nodal delay? How do you know that you don't just have delay up here in the AV node before it gets to just a plain old bifascicular block where the third hemifascicle is still healthy? So if you have a healthy posterior hemifascicle, then the ventricle gets the signal on time and everything is fine. You don't have to worry that this person has really severe trifascicular conduction system disease. How do you know that the prolongation of the PR is high up or is it low down? Well, you know, remember last time we talked about the location of the block when you have type 1 versus type 2, second degree AV block, but when you just have PR prolongation, you can't really tell where the delay is coming in. So you know what? The only way to know for sure where the delay is by actually doing a His bundle study. So that's when we put a catheter into the ventricle, we go up the vein, we put a catheter right near the bundle of His, and then we can measure exactly when does the His bundle fire. And why is that important? Because here, this is what an EP study looks like. I'm going to show you the screen that we use. You know, this is just one example of the recordings that we get in an EP lab. So if you've ever worked in an EP lab, these recordings, these squiggles should look familiar to you. Let me just zoom in a little bit. And on the screen, let me just add a layer here and draw in white so you can see it better. So on this screen, what you have on the top is just a P wave and then a QRS complex, and here's the T wave over here. So this is just the surface ECG just spread out because we can sort of change the time scale on the screen and see like little tiny details. So this second line is the high right atrium. So we can see a big squiggle right there that lines up with the P wave, and that's just the signal coming from the high right atrium. But this is the His bundle electrogram. That's what we call it when you put a catheter right next to the His bundle. Now, where's the His bundle? It's in the atrial septum, leading to the ventricles. So when you're in the septum, you can actually record signals from the atria and also signals from the ventricles. You see both signals. That's why in the His bundle electrogram, you have a giant atrial signal, that's the A wave, and then you have a pretty giant ventricular signal here that lines up with the QRS complex. But this little squiggle right there, this sharp deflection, that is known as the His spike. That's the His bundle activation. So when the His bundle fires, it sends out this little signal and we can record it with a His bundle electrogram. That's what these catheters are for. But more importantly, you can measure how long does it take to get from the top of the AV node to the His bundle, and then from the His bundle to the ventricles. Okay, so it lets you measure how much time it's taking to get down each part of the conduction system. So if you measure from the beginning of the A wave to the beginning of the His, that's known as the AH interval, and that corresponds with the time it takes to get through the AV node, because you're going from the atrium to the His bundle, so the AV node is what takes that much time. But when you measure from the His bundle to the ventricular signal, either the one that the catheter is contacting or from the QRS complex, that's known as the HV interval. And the HV interval tells you the integrity of the bundle branches, the His bundle and all the bundle branches. So the HV interval has a relatively narrow normal range of 35 to 55 milliseconds. So normal would be 35 to 55 milliseconds. Now, let's go back to trifascicular block. If the third hemifascicle, if let's say you have a right bundle branch and left anterior hemiblock. If the left posterior hemiblock is healthy, if it's intact, then the HV interval should be in the normal range, or maybe only a little bit prolonged. You get it? So if you measure the HV interval, you can tell how healthy is the third branch. Now, if the third hemifascicle is diseased, the HV interval will become long. So here's a recording from an EP study. And if you examine, here's the His bundle electrogram right here. And here's the atrial signal, the A, and here's the V. And your His bundle is over here. So when you measure the beginning of the H spike to the beginning of the QRS complex, you get 100 milliseconds. Now that's extremely long. And the HV interval should be between 35 and 55. So if it's like 60 or 65, it's a little long. If it's like up to 80, it's moderately long, but 100 is like, wow. So this is somebody where it's taking a long, long time to get from the bundle of His to the ventricles. So that tells you that you have trifascicular delay. It's being delayed in all three branches. Now, look at this. It's interesting because what you see here is in V1, you have a very wide negative deflection. In V5, you have a wide negative deflection. And so this is not a right bundle branch block. But what this is, in this particular patient, is here is an example of somebody who has a left bundle branch block and a first degree. So you have a typical big negative QRS complex in the anterior precordial leads, and you have a sort of a delayed notched upstroke QRS in 1 and AVL. So this is typical of our left bundle branch block, but the PR interval is long as well. So if we go back to our little anatomical drawing, okay, if I erase some of this stuff. Okay, so now let's say that you have a left bundle branch block. So now the left bundle is not depolarizing on time. So the signal has to go down the right bundle, get to the ventricle, and then gradually conduct through slow intramyocardial pathways to the left ventricle. And what that does in a left bundle branch block is it gives you a very slurred upstroke and a wide QRS in the lateral leads because it's taking a very long time to get to the lateral side of the heart. But when you have a first degree AV block, why is the PR long? Because in a left bundle branch block, you expect that the right bundle branch is going to be healthy and that the signal can get to the ventricle quickly on time with a normal HV. But in a left bundle branch block with a first degree AV block, maybe the right bundle is delayed as well. Maybe that is an indication that you have trifascicular conduction system disease because it's taking longer to get to the ventricle. But again, you cannot tell unless you actually put a wire in and measure the HV interval. The HV interval, if it's short, tells you that one of the bundles, one of the hemifascicles is conducting normally, and it's just two of them that are diseased. But if the HV is long, it tells you all three are diseased. And that's the kind of patient where it's equivalent to type 2 second degree AV block. It's not quite as bad, but let's say if you have a patient who fainted or somebody who's having dizzy spells or someone who's having periods of AV block, you might want to recommend a pacemaker sooner rather than later because trifascicular block is a harbinger of bad things. For the same reason that second degree AV block type 2, because of infranodal conduction system disease, is also more serious than type 1. Now, just to kind of throw a monkey wrench into this whole thing, I just want to show you one last cardiogram. Oh, I think I didn't open it, but let me find that file because it was really cool. Let me see. I'm sorry for the delay. Here it is. Okay, so I don't know, that's too big. So here's a really fascinating tracing. And what you see, let me just try to draw on it, is you do have an R prime in V1, okay? And you have a wide S wave in V5 and V6. The QRS isn't super duper wide, so but it does measure out to be 120 milliseconds. And you have a markedly negative QRS complex in 2,3 in AVF, and it's isoelectric in AVR. In fact, it's a little positive in AVR. So that gives you a QRS axis somewhere above minus 60. So what you have is a kind of an incomplete right bundle branch block with a left anterior hemiblock. But if you look at the PR interval, it's long, and then you actually have a P wave that does not conduct. And then the PR gets shorter again, and then it becomes progressively longer as you go through the tracing. So this is an example of Winky back in the setting of bifascicular block. And so the PR interval is long, and it's getting longer, 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 and dropping. But how do you? But the fact that the PR interval is changing, it's getting longer, and you have type 1 second degree AV block makes you think, well, maybe this PR interval is prolonged because of block in the AV node, and the bifascicular block is not really trifascicular block. It's just bifascicular block, and you have delay in the AV node itself. So it gets to be really tricky, and you can't just look at a tracing and say, trifascicular blocks, ha ha ha, I'm so smart. You really have to think about why you think there's trifascicular block, and some of it has to do with how the PR behaves. If it's variable, maybe it's AV nodal, but there's always the possibility that you have disease in that third hemifascicle that's causing the PR interval to get longer. So this kind of gives you an idea of where my head is when I'm analyzing electrocardiograms. If I'm reading a cardiogram, I don't always jump in and say, oh, well, that's bifascicular in a first degree, so that's trifascicular block. I don't always label it that way because you don't really know that the prolonged PR is due to trifascicular block. It could just simply be block in the AV node. And if you're concerned about the patient, if the patient has had symptoms and you're afraid that they may indeed have trifascicular conduction system disease, you really have the option of doing a His bundle study. It's a very safe procedure, even though it's invasive. It's like really nothing to it. So very little risk, and you get a lot of information to decide whether the patient needs a pacemaker or not. I'm just trying to think of whether there's any other issues that I wanted to discuss. Well, it is, as I said, a kind of puzzling problem, and it's something to think about, but understanding the physiology is the most important thing when you're reading a cardiogram. It's not enough to just rely on pattern recognition and say, oh, left bundle branch, first degree, okay, trifascicular block, and then label it, because it may not be. And you have to think about why you're labeling it that way. Why would a trifascicular block cause the PR to become prolonged? Think of it this way. This is what I wanted to mention. It's very important. If a normal HV interval is 50, let's say 55, maybe even 60, and a really markedly prolonged HV interval is 100, you're only talking about 40 milliseconds. 40 milliseconds is one small box. So if your PR interval is 240, it could be that your HV interval is 100 milliseconds and that the patient's conduction system is hanging by a thread. On the other hand, it could be that that extra 40 milliseconds is just coming from AV nodal delay. So if you see a really long PR interval, that doesn't always mean trifascicular block. In fact, you only have to have a slightly prolonged PR interval to be consistent with trifascicular block, because the HV interval is only getting longer by 40 or 50 or 60 milliseconds. So really, you can't tell. You just can't tell from the cardiogram. And if you have the ability to send the patient for an EP study, that would be a perfectly fine indication to get an electrophysiologist to put a wire in, check the HV interval, just so that you know whether this patient is okay. Because if they have a healthy third hemifascicle, then they can rely on that, and they don't really need a pacemaker. So I hope that was helpful. I'm doing these live streams to teach you how a heart rhythm specialist thinks about these things. And I'm trying to come up with more clinical cases, a case report with a history and everything, so you can get a better idea of management of patients. And if you really enjoyed this content, please subscribe to my YouTube channel at ECG Doc. Tell your friends. You can go on Facebook. My Facebook channel is ECG Academy. And if you want to learn more about how to diagnose hemiblocks and bundle branches and arrhythmias, then definitely check out ecgacademy.com. You can watch a whole series of video tutorials, and it's kind of like a private lesson with a heart rhythm specialist. So you can see how people in my business think. Well, thanks. If you're watching this live stream, I really, really appreciate it. And if you're watching it after the fact, well, I hope you enjoy it. Please subscribe, and so you can support my cause and I'm always having a hard time signing off of these things. What's the best way to say goodbye? Well, I guess goodbye from Dr. Nick. Thanks.